So PCOS, if you look at the etiological part of PCOS, it is many times it's a genetic hit or it is an environmental hit. A genetic hit, we really don't know the cluster of genes which are responsible for that, nor it has been identified. They tried to look at the type 2 diabetes mellitus genes, they looked at the metabolic syndrome genes, but still they could not identify a particular set of genes. Neither we have any genetic investigations designated for PCOS, so that's a different thing. What we understand is a polycystic ovary mother will put all the androgen to a daughter as a fetus, and therein her follicle numbers will go up and she will be born with a high AMH, and she will be born with a tendency of developing polycystic ovary. That's, let's put it, a genetic hit. The second is an environmental hit. Environmental hit is a typical insulin resistant hit, and that happens at 2-3 times in Indian scenario. One is when the girl goes to 12th standard. Okay, she either is chasing NEET or JEE or things like that. Home people will pamper her, she'll be sitting at one place, everything will be served to her. So in those 2 years, because of excess stress of exam, late nights, multiple classes, etc., this girl will typically gain weight by 6, 7, 8 kgs, and she is sedentary also, and because now obesity induced oligomenorrhea will be setting up, and she will set up a polycystic ovary. But these are insulin resistance induced. The second is a typical girl who just gets employed in a high target oriented company. So a lot of stress she's going through, she's into binge eating, she's not looking after herself from the exercise point of view. Again, a weight gain is noticed, and that causes a second hit could be there. The third hit, common hit, is she's a PCO, gets married and immediately has a first baby. And post first baby comes the ghee ka dabba, the dink ka laddus, and all the kind of badams and everything. So she grew by 20 kg in the pregnancy. She came down only by 3 kg post pregnancy. And now she maintains that with the stress of the baby there, everybody pampering her, 3 months of just massage. And I wish we had something similar in males here. 3 महीना सो के कोई massage करके दे तो क्यों नहीं ना? But unfortunately, we don't have something like that. And so that's it. And they don't come down at all. And now she struggles to have a second baby, because now she has insulin resistance, induced oligomenorrheas, and now she's on PCO. So these are the ways the PCOS, you can say, evolutionarily could be there. And there's one nice Helen Masson story. She tells it this way. Helen Masson is a biochemist, but her knowledge on PCOS is so much that RCOG gave her a clinical permit to practice polycystic ovary medicine, because she's a biochemist actually. Very few. Richard Fleming, from whom we learned long protocols. He is the high-flying consultant in PCOS management or reproductive endocrinology. He's a biochemist. He's not a doctor. He has an honorary FRCOG now. But these people escalated to that level. So Helen Masson tells us, so you have a fat women were there anciently in all communities. And these fat PCOS women wouldn't conceive. Okay, and they were androgenic, so they were better runners, better hunters, and could get the hunt and the food very well. And those in hunter-gathering years, probably the other women who were normal menstruating got pregnant also. And one of the largest cause of death would be maternal death, because the obstetric labors and obstructed labors, etc., could go to death. So the average livelihood for a lady was about 25 years or 30 years. But this lady wouldn't get pregnant. So she would live longer. She would probably be serving as a surrogate mother, taking care of the children in the community who have lost their mothers. And she must be the most sought after lady by men, because she's a hunter. The man can sleep at home and she'll hunt something for him. So insulin resistance then was great, but then came the sedentary lifestyle. And though a bearded lady or a fat, obese, infertile lady has been described in literature in recent past also. So typically a war or famine will come. With war and famine, everybody will lose weight. So a normal menstruating lady, when she loses weight, she becomes hypothalamic amenorrhea, and she goes completely amenorrhea, so she won't reproduce. Well, a PCOS will reduce weight, and now she'll reproduce. She'll pass the genes to the next generation. Obviously, war will end, a famine will end, but for Israel and Gaza. Hopefully it is ended. But then that will pass on to the next generation. Once the war ends, they will again gain weight, and again the offspring will become amenorrheic, and she'll also become polycystic ovary. So evolutionarily, polycystic ovary is seen in all communities over decades and decades. Just put bearded lady on Google. In every literature, Roman literature or Jewish literature, a bearded lady has been described. So that's what, insulin resistance has always been a core of aggravating polycystic ovary or causing polycystic ovary. Acne, hirsutism, oligomenorrhea, infertility are the younger. As the younger, you're more treating the acne and cosmetic part of it. As you grow older, you're more treating about reproductive disorders like adenomyosis, fibroids, type 2 diabetes, because they maintain a long time hyperestrogenic status. The chances of reproductive disorders are pretty high. And obviously endometrial and breast malignancy come when they touch the menopause. So PCOS women tend to suffer from all these scenarios. We are only here to manage the infertility part of it and a bit about hirsutism and acne. I'm not going to go through this. So what is the scenario? We have a high AMH PCO, lean, tall, high LH, a typical lean polycystic ovary, what you call, and they could have insulin resistance, they may not have insulin, they could have high androgens, they may not. Second is a high LH, obese, moderate AMH lady, again, may have insulin resistance, may not. And last is the obese, normal LH, polycystic ovary morphology, and she is a typical PCOS, which is very amenable to management by diet control. And we are going to look at the AMH, LH, the fat distribution, the preventive strategies, etc. So let's go hormone by hormone and how we understand PCOS. मैं रुकूँ या चालू रखूँ? 15-20 मिनिट लगेगा. Then we'll have a coffee break. Huh? Right? अशोक कॉफी फक्त सांगून ठेवूया त्यांना. For AMH, see, AMH is so much important in polycystic ovary, isn't it? AMH is going to tell you the clinical severity of a disorder. So this is also a sentence I use when I counsel my PCOS. I say it's a spectrum of disorder. It is my job to investigate you, to find out what part of the spectrum you are. Are you on a bad part of the spectrum and are you on a good part of the spectrum? So then they understand why I'm doing all those investigations. But AMH is not a part and parcel of definition of polycystic ovary. Am I right? AMH is a part and parcel now by Barcelona criteria of definition or a surrogate marker for polycystic ovary morphology, because transvaginal scans are not possible in Eastern oriented adolescent girls, and we highly depend on AMH as a surrogate marker of polycystic ovary morphology. So AMH is equal to AFC. So that's how we correlate. Otherwise AMH is of no part of the definition at all. So we should have an age-specific cutoff of AMH for PCOS. Suppose you say your age-specific cutoff is 3.5 at all ages, then at 25, probably 60% of your population will be polycystic ovary, and at the age of 40, maybe 10%. But suppose you put a cutoff of higher, 6.5, at 40, you won't have a single patient of polycystic ovary, and at 25, you'll have 10% patients. So you need, at what age a separate cutoff should be there, because the AMH keeps on falling. So you need an age-specific cutoff, and this is a normal cutoff which has been described in the literature. Between 20 to 27 is 7.4, 5.16 between 27 to 35, and beyond 35 is 4.72. So these are specific cutoff. If your lady has these SMH, the more likely that she is having polycystic ovary syndrome. Why AMH is important? AMH is an aromatase inhibitor. The moment you have an aromatase inhibitor, your FSH action is not going to be possible there. The pointer hota na? Pointer tithe kela. So this is a paper on baseline AMH levels assisted with ovulation following ovulation induction women PCOS. So they looked at the AMH level and who ovulated, who did not. And look at the no ovulation. Overall no ovulation had a high AMH. Overall clomiphene also high AMH, did not ovulate. Letrozole also high AMH. So what we understand is if the AMH is higher, the chances of ovulation for simple medication is less. So elevated anti-malarial hormone is an independent risk factor of preterm birth. Now, AMH is also related to preterm birth among patients who are overweight and polycystic ovary. And there are two papers, highly elevated AMH associated with preterm deliveries in PCO women. So AMH, it is a pro-apoptotic on Mullerian system. It's pro-apoptotic, a anti-Mullerian hormone. Okay. So if there was anti-Mullerian hormone in that lady, she would not be lady. Am I right? But AMH becomes the significant part of making her a lady, a complete lady. Okay, so it's paradoxical. So AMH is pro-apoptotic Mullerian system. AMH receptors are still there in the myometrium, and that may limit myometrial hyperplasia. This is a hypothesis put forth. So high AMH women are at risk of having preterm birth. What about LH? So when it comes to AMH, I just understand higher the AMH, worse is the polycystic ovary. That's all I understand. A word on polycystic ovary morphology. Even if one ovary has polycystic ovary morphology, it is still polycystic ovary syndrome patient. It's not necessary that both the ovaries should be having a polycystic ovary morphology. Again, you will notice women who have very bad PCOS will have some kind of uterine problem. Okay, like unicornuate uterus, arcuate uterus, or I call it a triradiate uterus. So patients with bicornuate, diadelphi, very commonly you'll have PCO. So it all starts intrauterine. I think somewhere, this is not mentioned much in the literature, but it's just my hypothesis, I can say, that somewhere androgens are responsible for this cloaco-allantois differentiation. And why the Mullerian ducts move to the center, some androgens could be playing a regulatory role there. And having a hyperandrogen may not be one of those conducive things to take place. And that could be reason why this triad of having polycystic ovary, irregular cycles, and uterine abnormality is commonly seen. What about LH? We understood FSH-LH altered ratio as a diagnostic factor, but it's a totally gone definition. Don't even utter that sentence. Okay, even in conference, somebody is talking a lot about LH and FSH alteration. Just leave it. This is nothing. It's all past. Anybody talks of giving steroids for polycystic ovarian stimulation, past. No paper published beyond 1995. So we should not be discussing and talking about it. And don't clutter the mind with that. So LH pathophysiology, why do you have a high LH? So LH responds to GnRH. For the amount of GnRH released, the amount of LH released from the pituitary in these PCO women is higher than the other women. Why? When they started knowing about AMH, they found an AMH receptor in the hypothalamus. And they were wondering why the AMH receptor is there in the hypothalamus. Probably that, if satisfied with high AMH, could be altering this mechanism of hypothalamo-pituitary axis. Again, a hypothesis which you can put. Then you have obesity. With obesity, more androstenedione, peripheral aromatase converting to estrone. Estrone, chronic estrone, high, coming from such a high obese cells. So the estrone is high, the LH will go up high, and LH high, so more androgens, and the whole circle gets completed. So the LH high could be because of that reason. LH not suppressed. So ideally, as the follicle grows and E2 goes up, or as it ruptures, progesterone goes up, it should negatively suppress the LH. But that doesn't happen because in utero, because the pituitary of the female fetus is more exposed to the maternal androgen, this mechanism is attenuated. That's a hypothesis put up. So high estrogen and high progesterone cannot suppress the LH activity. That could be a reason again that the LH tone persists. Insulin resistance and insulin growth binding protein 2 decreases, so IGF is increased. Because IGF is increased, more follicles grow. As they grow, they obviously secrete more amount of androgens and everything goes and falls into place. So these are the various mechanisms described why you have a high LH in PCOS. So there is always an increase. The tone of LH in PCOS is high. There's increased mean LH pulse frequency and amplitude. LH will increase androgens, and that's why PCOS is also called functional ovarian hyperandrogenemia. When Rotterdam criteria came, there were some German doctors, German doctors, they did not agree to that because Rotterdam criteria phenotype D, it was a high debate that whether if you're not hyperandrogenic, how can you be labeled as polycystic ovary? And they started labeling it as functional ovarian hyperandrogenemia. The phenotype D really created a lot of issue. So in America, they had a PCOS society, but they labeled the society as Androgen Excess and PCOS Society of USA. It was called. So they believed so much on androgen excess, which is rightly so. So all the things about androgen excess came a lot from America because it's a population of immigrants, a lot of Japanese, a lot of Koreans, Singaporeans who won't have hair with high androgens. So there have to be biochemical hyperandrogenemia is important. While in European population, there will be Middle Eastern, European, not much of these immigrants, and Indians now. So we all have hair, so it is easy to diagnose on clinical hyperandrogenemia criteria. So Rotterdam was clinical hyperandrogenemia also, while the newer definition says biochemical hyperandrogenemia with a serum free testosterone beyond a certain cutoff. High serum LH may not be the only reason of functional ovarian hyperandrogenemia, because obese PCOS, a lot of obese polycystic ovary have a normal LH. So what happens is, see, as the LH goes up, more and more androgen comes, but there is a ceiling to that. But there is a ceiling. Beyond a certain LH, no more androgen will come up. Okay, but that ceiling is broken by insulin resistance. That's where the insulin acts, and that it breaks it up, and so the androgens keep on varying. Hyperinsulin helps to escape this theca cell desensitization, and the androgens keep coming in. High LH because of abnormal sex steroid feedback. I just told you about it. LH pulse frequency is not sensitive to negative feedback by estrogen and progesterone. Androgens intrauterine attenuate the negative feedback, and hence LH rises. So all these mechanisms I'm just repeating to you. So prenatal exposure to excess androgens, AMH receptor in the hypothalamus sets in more LH release in response to normal GnRH pulse. And that's the reason you have a high tone of LH in polycystic ovary patients. So what are the LH levels in clinical practice? Low LH is less than 1.2 to 0.8 threshold. This is the LH which is necessary for all your stimulations. Hyper LH is this. Then what is premature luteinization? Forgive me the spelling. A high LH with progesterone of beyond 1.5, or higher a normal LH, when the progesterone is beyond 1.5 during the course of your stimulation, you call it premature luteinization. And what is LH surge? LH going beyond 17, or LH going beyond 20, or the definition I talked in the morning of estrogen coming down, the Irani definition which I talked to you about in the morning. What about obesity? We discussed a bit on AMH, we talked about LH. Let's talk of obesity. There is something called an insulin story. So if you culture the granulosa cells with testosterone-rich media, it did not increase the insulin levels. But if you culture the granulosa cells with insulin-rich culture media, it detected testosterone. So don't treat the androgens. Treatment intentions should be targeted to decreasing insulin and not androgens. So in PCOS lectures, you have never heard of giving spironolactone. It's for acne and hirsutism, but you never heard of, you give this for 3 months and then start stimulation, isn't it? Or give OC pill for 3 months and then start. We never heard of that, because androgen, we don't treat the androgen, it's the insulin we like to treat. So target your therapies or interventions to insulin resistance coming down, androgens will automatically respond. Insulin resistant PCOS, the insulin mediated glucose uptake is reduced, but steroidogenesis is high. See, I told you insulin resistance means the follicle will not grow, anovulation. But steroidogenesis is high because the LH keeps high. Insulin augments LH stimulated testosterone. The amount of testosterone released in response to LH is also high. Increased insulin upregulates LH binding sites. Insulin increase E2, P2 production from granular cells, and more, this is what, fatty liver, non-alcoholic fatty liver disease also seen. Top quality embryos higher in women losing beyond 10 kg weight. So if the lady says, I will reduce weight and do for IVF, you ask her, are you able to reduce 10 kg? If you reduce 10 kg, it will make a difference. Or forget it, let me just increase my dose by 150 IU, it will do wonders to you. So there's a beautiful paper, 2 papers, I always quote these papers. One by Divas et al. He published a paper and he said the PCOS phenotype makes a difference to the embryo output. But what he did in his PCOS IVF stimulation was he gave 150 to 225 IU. He gave HCG trigger, and he did fresh embryo transfer followed by frozen cycles. So this is something which we don't do in our PCOS patient. So when you use a low dose, you are not combating the LH AMH resistance and obesity resistance on the follicular growth. So obviously the phenotype will alter your results. So Sherry Macklin did another study in polycystic. She just increased the dose to 300 IU. The moment she made it 300 IU, the phenotype did not matter at all, whether it was A, B, C, D. In all phenotypes, she got 20 follicles and more. So the secret of success in PCOS, just go full throttle. Women had lower implantation rate is also there, some endometrial issue. Insulin suppresses insulin growth factor binding protein 1. Because it suppresses that, IGF-1 is free and increases. It stimulates the theca cells to produce more androgen, because your first growth from primordial to the preantral requires IGF-1, and that's the reason you give growth hormone in your poor ovarian reserve client as well. Obesity will also decrease insulin growth factor binding protein 1, and insulin resistance suppresses sex hormone binding globulin. So the marker of hyperandrogenism in PCOS is low sex hormone binding globulin level. You will commonly have normal testosterone, normal androstenedione, but sex hormone binding globulin is low. That's why more free androgens are there, and that's why the lady is more androgenic. Hashimoto's thyroiditis is very common in PCOS. Insulin resistance, polycystic ovary, hypothyroid goes together. 1 in 7 PCOS in India could be having hypothyroid. 20% they will also have hyperprolactin, so don't easily define hyperprolactinemia. Prolactin inhibits sex hormone binding globulin, positively correlates with high TSH. So low prolactin also means low prolactin has higher metabolic syndrome. So all these things go hand in hand in PCOS. What about metformin and inositol? I think it's our favorite, inositol, ESHRE conference guaranteed. So if you give pump in inositol a lot, I said guaranteed and the AI recognized something here. So metformin inositol improves insulin resistance. Metformin does not increase clinical pregnancy rate in IVF and ICSI cycle. So gone are those days. Okay. Sharyu looked into all the data on metformin and IVF, but for papers on long protocol and metformin usage, there was no role of metformin. Got it. So we don't use long protocol. So there's no role of metformin. No need to put metformin into PCO. Androgen levels decrease modestly, only few studies, because longer metformin only decrease androgen levels, not a small metformin. So metformin offers correction of the metabolic syndrome of the PCO, not the endocrine syndrome. And endocrine syndrome is important for your ovulation induction. Metformin can we offer in PCOS pregnancy to decrease androgen passage to fetus? That's an important thing. So this Ichiburo et al. 2020 study, metformin protects offspring from DNA methylation changes due to leptin and adult onset disease. The Bacchus hypothesis is prevented. So this is one use of metformin in pregnancy, that you will be stopping the passage of androgens and making the fetus at risk. Metformin pregnancy, no increase in miscarriages, preterm labor, no cognitive function problems in the baby. PEDMET study said it is of no great use. Interleukin 12, I'm leaving that up because we don't use it up. When to intervene in PCOS pregnancy? 16 to 24 years till a pregnancy is planned. It's just lifestyle and diet. Prior to embarking fertility treatment, you can go lifestyle, give a pump in a lot of vitamin D because it increases the metabolic syndrome at the granulosa cell level. Obviously a low carbohydrate diet, and nothing wrong in using a GLP-1 agonist like semaglutide or liraglutide and reducing some amount of weight. So what about weight loss? So this is the effect of weight loss before IVF in obesity overweight. This is a systematic review which has been published. Weight changes with intensive diet restriction were 5. See the weight change is only this much. And with medication was only 2.49 kg. So only single digit difference. What improvement will it do? So no improvement in live birth rate with weight loss. Odds ratio was crossing the line of unity, no improvement. Clinical pregnancy rate also crosses the line of unity. Miscarriage rate remains, again, no change at all. So just simple weight loss before the IVF is not going to make much difference from the IVF outcome. Again, coming back to the same story, fertility first, higher doses and go ahead. What about GLP-1 agonist in IVF this is a nice paper, role of GLP-1 agonist in reproduction from physiology to therapeutic perspectives. There is GLP-1 agonist is your liraglutide and semaglutide. There is one more molecule which has been recently introduced. I don't know about it. Ovulation rate and menstrual frequency definitely increased natural pregnancy rate, increased IVF pregnancy. So if you use pharmacotherapy plus carbohydrate diet, low carb diet, it will definitely make a difference because you will get substantial weight loss and the parameters will increase. What about bariatric surgery? A nice paper. This is it's a national register-based case control study. Women have high expectations of regaining fertility after bariatric surgery. However, obesity-related infertility is not yet an indication for bariatric surgery. Okay. So when it comes to, I finished with this. When it comes to bariatric surgery, in PCOS, do we offer it? I suggest everybody with a morbid obesity, you get those bad ones with 100, 110 kg PCOS, I would prefer them going for a bariatric surgery, no doubt about it. But all the trials are suggesting it makes a difference. Their ovulation returns back to normal. their menstrual pattern is obviously established well, the chance of spontaneous pregnancies also go up, and your IVF will become more comfortable. Only thing is they must have a high AMH PCOS. If you have a normal AMH, PCO, or your AFC is also normal, or a non-PCOS obese, going with a bariatric surgery will decrease the chances of fertility, because the AMH and follicular reserve will come down very, very badly. Well, thank you so much. Any questions on